Welcome, everyone. I'm Eric Weiner, and I have actually been the Yale Cancer Center director and the physician-in-chief at Smilow for all of 8 days. I suppose you could say that I've been around a little bit longer because since being offered the position and accepting it, I've been very involved by Zoom and a little bit in person for the past 2 to 3 months. And I dare say that's given me a running start and has been very helpful. I just want to start off with about 5 minutes, both about who I am and why I came and my vision, and I'll do my best to be relatively brief. So I have the distinction of having only lived in 3 cities in my entire life. I grew up in Boston. At age 17, I came to Yale as an undergraduate, managed to extract myself from New Haven 13 years later after completing college and going to medical school and doing my internal medicine residency. I spent 10 years down at Duke in North Carolina and then moved to Dana-Farber Cancer Institute in Boston, where I was for a little more than 2 decades. And at Dana-Farber, I directed our breast cancer program and had a variety of other leadership jobs over the past few years. And I suppose if I have any claim to fame, that claim to fame is that I'm a breast cancer doctor and researcher. Over the past few years, I've wondered whether it was time to do something a little different, and I looked at a number of different positions, and ultimately decided that this was really the right fit for me. And it was the right fit for me because Yale has great science, Yale has great clinical care, and very strong clinical research. And it has huge potential because by bringing all of those elements together, I fully believe that we can have a world-renowned cancer center and program in oncology. And what that means is that we will provide truly unsurpassed care to patients, unsurpassed in all ways, both in terms of the technical aspects and some of the perhaps warmer and fuzzier parts of cancer care, for lack of a better way of saying it, meaning that we take care of patients and we take care of their families. And when they come see us, from the minute they make that call until they no longer need our care, they feel like we're giving them a big warm hug. And I think that that's really important. I often say that one of the remarkable things about being a doctor who takes care of patients with cancer is that there are relatively few opportunities when, as a doctor, you are suddenly given a door into people's lives. This isn't true just for doctors, it's true for nurses and social workers and everyone else who works with us clinically. But if in fact you choose to go through that door, it's a pretty rich experience, and I think that we can do quite remarkable things for people, and at the same time, while we're doing those things, there are important lessons for us. So my vision is that over the course of the next 5 years, 10 years, there's no real specific point in time when I think that we can say that we will have accomplished what we're striving to do, but that we will be truly a world-renowned program in all the ways that I described to you, both clinical, both in terms of clinical care, but also very, very importantly in terms of research, because we all know that while we have been much more successful in treating cancer over the course of the past 10 years, there's still a long way to go. There are many people both in the United States and even more so around the world, but still very much so in our own country, who suffer far more than they should, who lose their lives prematurely, and who have to go through an experience that, of course, we don't wish on anyone. So when we get to the point where all cancers can be treated with the equivalent of penicillin for the strep throat, then I think maybe our job is not done, but we will have really accomplished something. And I think that's actually a place where we can be. And when I say we, for this, I mean we very broadly, those of us at Yale and those of us who we work with around the country and around the world. So I think that's enough about where I think we're going and who I am. And let's move on with the program. We have really a great program. We have 3 sets of speakers, and we're going to start with clinical updates from Kevin Billingsley, our Chief Medical Officer, and Kim Slusser, who is Vice President for Patient Services and Chief Nursing Officer of Smilow. So Kevin and Kim.
Well, Dr. Weiner, thank you. I know I speak for all of us in our community in saying that we are absolutely thrilled that you are here, and it is great to have you with our patient and family forum audience this evening. So it's an exciting time. And Kim and I are both pleased to give this clinical update. Next slide. You know, I don't think it is any secret to our audience this evening that we continue to work our way through a pandemic of really unprecedented proportions. And, you know, these data demonstrate what we've been through in the past 6 weeks here in Connecticut, fueled by the Omicron surge. In early January, we reached an all-time high of daily case rates in Connecticut and nearly an all-time high in hospitalizations. And I will share that Yale New Haven Health System was on the very forefront of caring for this group of patients and families. And although we are a cancer center and caring for our cancer patients is job number 1, we also feel that we're important citizens within a larger healthcare system. And all of our teams have made contributions to caring for COVID patients in various ways, shapes, and forms, not only within COVID, within our particular patients, but also contributions to the care of COVID patients across our healthcare system. I'm not going to share specific data, but I do want to comment that this health system cared for a significant majority of COVID patients in the state over the past 6 weeks. And our outcomes were absolutely spectacular. The success rates driven by our protocolized treatments were the best in the state. So again, I just want to take a minute to say thank you to all of our teams who've contributed to this. Next slide. The overall story is, in recent weeks, good news. As you can see from these graphs, across our health system, we went up to over 700 patients, you can see in the blue line. And as of this morning, we're down to 144 COVID patients in our hospital system. And here in New Haven at Yale New Haven Hospital, after going up to about 450 patients in the hospital, fortunately, we're down to 88 inpatients. And fortunately, the trend continues in a positive direction. So good news all around. Next slide, please. You know, one of the things that I am most proud of for the work that our teams have done in recent weeks is that what we have learned is, although the pandemic certainly creates a stress on our healthcare system, it is absolutely critical that we continue to provide healthcare to all of our patients, particularly our cancer patients. And this is a graphical display of our ambulatory visit volumes across the Smilow system during the weeks of December into January, really at a time when the rates of Omicron-driven COVID infection were soaring. And you can see we took a dip in our visit volume right around the week of Christmas, as you would anticipate. And then as the height of the surge hit, we did transition many of our visits to video and phone, keeping a number of potentially vulnerable patients and families out of our physical facilities, yet we maintained our overall visit volume and our care visits virtually without interruption through this surge. Next slide. The other thing that we learned was really challenging during the first wave of the COVID-19 pandemic was that at that time in 2020, we really shut down many of our surgical procedural areas. And during this most recent surge, we were absolutely committed as a healthcare system and a cancer care enterprise to continuing to provide surgical care to cancer patients. And again, you can see that in late December, we had a drop, but really continued to provide surgical oncology care in a very uninterrupted and ongoing way. Next slide, please. Similarly, our patients who are on receiving radiation therapy continued to receive their daily treatments at all of our locations across the system, virtually without interruption. Next slide, please. So it has been a really, I think, challenging yet successful period of time. And I, again, want to thank all of our teams. I'm really pleased that we've been able to care for our patients through this difficult period. Kim, over to you.
Thank you, Kevin. As Kevin mentioned, we're just coming off the heels of another surge, and we constantly want to make sure that we're doing everything that we can to keep our patients, their loved ones, and our staff safe. So one of the new requirements, as we got guidance around booster vaccination, is that all of our faculty and health system staff are now required to get their booster vaccinations. This is a way to, again, increase safety within the walls of the care that we provide you. We know that the COVID-19 vaccine boosters have a substantial impact on reducing COVID-19 infections, severity of illness if you were to still get COVID-19, hospitalization, and death. So we are very proud to know that all of our faculty and health system staff are getting their booster vaccinations. I wanted to take this time also to update our visitation, what's going on with visitation across the health system and within Smilow. I know that this can be very confusing for our patients and their loved ones, and sometimes even for our staff, because we do change visitation guidelines based on what's happening across our state and within our health system. Right now, for inpatients, for patients that are hospitalized, they can have one visitor accompany them. And also one visitor can now accompany patients as of last week to outpatient appointments. For the inpatient guidelines, it is just one visitor per day though. We do not allow more than one visitor, to visit, even if it's at a different time. So we only allow one visitor that day, and then the next day, if there's another visitor that would like to visit that patient, they can be the one to visit. But we do try to still have, try to limit the amount of traffic that we have coming in and out of our hospital doors. Our visitors that are visiting our inpatients have to have proof of being fully vaccinated. There is no booster requirement right now for our visitors. If they're not vaccinated, they have to show proof of a negative PCR test within 72 hours. And visitation is not permitted for our COVID positive inpatients. And for our outpatient guidelines, like I said, we are, as of last week, allowing one visitor per patient, but there are still social distancing guidelines that we are trying to maintain. And there are times where some of our sites just really challenge us to keep that safe social distancing. So there may be times where we talk to our patients and their loved ones about not having a visitor come with them because of space constraints. But the pretty much the guideline is, if you're coming for your clinic visit, you can have somebody accompany you. If it's your infusion visit or radiation treatment visit, there may be times where you are asked not to have a visitor accompany you, but that will be discussed with you depending on the site. But we are very, we want our patients to have their loved ones with them. And we know this has been very challenging. So we are glad to see that we are able to have some visitation. And again, this may change as time goes on over the next few weeks, and we will continue to keep you informed on our website and our social media. And with that, I'm going to stop sharing. And I will turn it back over to Dr. Weiner. But thank you again to everyone on this call for trusting us with your care. It's really a privilege, and we take it very seriously, and we do everything we can to keep everyone safe during this time. Thank you.
And I don't know whether the audience can see this or not, but there are actually 260 participants on this call. And I can imagine that at some computers or iPads that there's more than one person there. So really, thanks for being part of this. So our next item is pharmacy and clinical practice updates. And I'm going to turn it over to Osama Abdelghany, who is the executive director of the oncology pharmacy, and Lisa Barbarotta, who's the program director for oncology education and clinical practice. And finally, Dr. Scott Huntington, associate professor of medicine and medical director of the hematology outpatient clinic. So I turn it over to the three of you.
Thanks, Dr. Weiner, and thanks to everybody for joining tonight. It's exciting to see so many people join. I'm just going to take a minute to open up my slides. Can the other panelists see the slides okay?
Ken, you're not in presentation mode, but I don't actually see the typical screen that allows you to go into presentation mode.
Let me try again.
If not, it's okay. I mean,
How's that?
It's
my slide mode. Here we go.
There you go.
Perfect.
Perfect.
Oh, sorry, there must be a delay. Sorry about that, everyone.
Okay.
So we're going to be discussing some complex topics this evening, and some are still actively evolving even as we speak, and I'll give some additional explanation to that as we go through the slides. We're really going to do our best to give you specific answers to all your questions. So we expect that some of the guidance we're going to be providing tonight may be a bit more general until we learn more information over the course of the next week or so. We thought it was important to start with a definition for immunocompromised. This is a frequently asked question that we get on our town halls and that we all get contacted for via various routes. This definition is our COVID vaccine guideline working definition for immunocompromised. And you'll see that this is a very broad definition for immunocompromised. The immunocompromised population is large and includes a range of those who may not be at significantly increased risk, all the way to patients who are the most severely immunocompromised. However, in regards to our vaccine recommendations, we opted to take a very cautious approach and really recommend a 3-dose vaccine series for patients that meet the definitions outlined here. So that includes any patient with an active blood cancer, even if you're not actively receiving treatment for that cancer, patients with solid tumors like breast cancer, lung cancer, colon cancer, and others who are being treated with chemotherapy, hormonal therapy, immunotherapy, or even patients who have had surgery for cancer in the last year, and as well as patients receiving radiation therapy. Of course, we include our patients who've undergone stem cell transplant within the last 2 years, or those who are still on immunosuppressive medications, as well as some other populations you'll see outlined, including solid organ transplant recipients, patients with primary immunodeficiency syndromes, patients with advanced HIV. And then you'll see a long list of medications at the bottom. And those medications are not just used to treat cancers, but may be used to treat other types of non-cancerous conditions, but those patients are still considered immunocompromised and needing additional protection. And I'll just call out rituximab is on that list, and that's a medication that's used very frequently, both in cancer and non-cancer indications. And we recommend a 3-dose vaccine series for those patients. And I'll talk about the vaccine definitions on the next slide. The other frequently asked question that comes up that I'll just call out here, we get a lot of questions from our CLL population about whether they meet the criteria for immunocompromise, even if they're not on treatment. And according to this definition, any patient with CLL would fall into this category. So then I wanted to just clarify our vaccine terminology, because this can be very confusing, but I want us to get into the habit of thinking about the terminology primary series and then booster vaccination. So for a person with a healthy immune system, so people who don't meet one of the criteria on the previous slide would get a 2-dose mRNA vaccine. So 2 doses of Pfizer, or 2 doses of Moderna, or 1 dose of the J&J vaccine. Patients that meet one of those criteria from the previous slide and are considered immunocompromised, their primary series is defined as 3 doses of an mRNA vaccine. And so that is a frequently asked question. I'll give some examples on the next slide, but I want us to start thinking about the primary series for immunocompromised patients as 3 doses. A booster is a shot that's given at least 5 months after completion of the primary series. And again, I'll give a couple of examples on the next slide. And immunocompromised patients who have completed that primary 3-dose series are eligible for a booster or a 4th shot, which we're really trying to move away from that terminology, after they complete their 3-dose series. Now, some of you may have heard in the press and via social media that the booster timeframe may be changing to 3 months. And I just want to take a minute to explain that the CDC has an advisory committee called the Advisory Committee on Immunization Practices, or ACIP. The ACIP advises the CDC on vaccine related items. And so the ACIP met on Friday, and they made some recommendations about vaccination for immunocompromised patients. And one of those recommendations is that we decrease the time frame for the booster shot from 5 months to 3 months. However, Yale New Haven Health System is not changing their policy or their guidelines until the CDC formally issues their recommendations. And we know that based on past history with COVID, that the CDC takes some time to review the ACIP's recommendations, but we expect the CDC to be coming out with more information in the next week to 2 weeks. So as of today, Thursday, February 10th, the timeframe for boosters for immunocompromised patients remains 5 months, but I'll just ask everybody to stay tuned. And our health system vaccine website should really be what we call the primary source of truth, or the one place that you all go to get the most updated information, because the health system will be updating that website as information changes and as the CDC makes their final recommendations. So we wanted to just include a pictorial of the vaccine series as I just defined it. So if you meet the criteria for immunocompromise as previously described in the first slide, your primary vaccine series is those 3 doses, followed by a booster dose at this point 5 months after the 3rd dose. And I'll just give a couple of examples because I think that would be helpful. So I'm a person with a healthy immune system. So I received 2 doses of the Moderna vaccine. 5 months after my second Moderna vaccine, I got my Moderna booster shot. I have a patient who is a 36-year-old who meets the criteria for immunocompromised. She received her 3 primary dose series with Pfizer, and 5 months later, she received her booster dose or her 4th dose, which we're really, again, trying to move away from because we know that inevitably there will be additional doses, so that everything after the primary dose, we will really start to refer to as a booster shot. Now, we haven't really talked about the Johnson & Johnson vaccination much. We know that we recommended for the majority of our patients that they receive Pfizer or Moderna, one of the mRNA vaccines, but we know that some of you all were very good and quick to get vaccinated, so some may have received the J&J. So again, at this point today, the recommendation for those who received J&J should have had a primary dose followed by 1 booster dose. Again, we suspect this may change with the ACIP's recommendations on Friday. So this is another area I'll just ask you to stay tuned to. And I think the other frequently asked question as it relates to boosters is, well, okay, I completed my primary 3-dose series and I'm getting my booster now. When should I get another shot? And we don't have an answer to that yet. We know that every year we get a flu shot and that the flu shot doesn't last forever. We don't have an answer yet on the frequency with which we're going to have to continue to get COVID vaccination. So that's another stay tuned. If you meet the immunocompromised definition and you have not yet received a 3rd dose or you have not yet completed your primary series, the recommendation is that you complete your primary series and get a 3rd dose. And then 5 months after you complete your 3rd dose, you will be eligible for a booster. And again, if that time frame changes to 3 months, then you would follow that. I just want to reference our vaccine scheduling site. As I mentioned, that this is updated and actually contains all of the information I just reviewed. It includes the definition of immunocompromised. It outlines the difference between the 3rd dose and the booster dose. And you can see here, if you walk through it to schedule yourself, if you look at the 3rd bullet down, I'm scheduling my 3rd dose because I am an immunocompromised patient and I've completed my 2nd dose at least 28 days ago. So if that's you and you haven't received a 3rd dose and you completed your 2nd dose at least 28 days ago, that's what you would select. If you've completed your 3rd dose as an immunocompromised person and 5 months have passed, you would select the 4th button and then you would be able to schedule your booster dose. I know that that's very confusing and continues to evolve as mentioned, so please stay tuned. And I am going to hand over to my friend Sam, who's going to talk about Evashield, which is another very popular topic.
Thank you, Lisa, and good evening, everyone. While the vaccine remains the main and the best defense we have against COVID, we want to share some information with you about a new drug that just became available as of December to prevent COVID infection. The drug is Evashield. It's actually made of 2 different drugs formulated together, and both of these drugs bind to different parts of the virus, and by binding to the virus they neutralize it and prevent infection. The FDA made this drug available in August under emergency use authorization, and I'm sure most of you heard that term already. It's a mechanism for the FDA to make experimental drug available before full approval when there's public health emergency, and obviously we are in the middle of one. So that FDA approved this drug specifically to prevent COVID-19 infection in patients with weakened immune system. The definition here, patient with moderate to severe immune compromise, which encompasses most, if not all, our patients. An idea here that this drug can be used in these patients because they have inadequate response to vaccinations. The drug was studied in 1 clinical trial where it was compared to a patient got the active drug and the other half did not. And there was a big reduction in the number of patients who had COVID infection with symptoms, about 77% reduction. In terms of side effects, it was generally safe and well tolerated in clinical trials. So there's no safety concerns in terms of side effects. And you can see here that most side effects were headache, fatigue, and cough. And as you expect from an intramuscular injection, there was some bleeding at the injection site. The way we administer the drug is 2 intramuscular injection given back to back in the same visit in the buttocks area. And after the injection, we ask that patients be monitored in the clinic for about an hour. Next slide, please. I don't know if you can able to forward or delay. Okay, well, the slide moves. I think it's moving slowly. I want to highlight some of the important factors that we want to mention about this drug. While it's effective in preventing infection, at least in this one clinical trial, it was really never studied in patients who got in the vaccine. The study that was conducted was before any of the vaccines were available. So we don't know how effective this drug in today's environment where most of our patients already gotten more than 1 dose of vaccination. It's not approved to treat patients who already have COVID infection, and it's not approved for patients who got exposed to somebody with infection. So it's really truly a preventive method in eligible patients. And like I mentioned in the beginning, this is not to substitute for vaccination because it is the best, vaccination is the best option we have today. And only other caveat in terms of safety, because it's an injection in the muscles, it needs to be given in caution with patients with low platelets or bleeding disorders. So that's something we monitor for and make sure that the selection criteria is accurate. Next slide, please. So where are we today? Because before the meeting and throughout the last few weeks, we've gotten a lot of questions about Evashield, where it's available, is available to me for me today. And so we highlighted some of the patient population that are eligible for this treatment today. The reason we had this specific patient population to start with is that the amount of vials, the number of doses that we got when this program started. The government bought 300,000 doses for the entire country early on. They distributed that throughout the country, state by state, and we had an allocation. So because of the limited supply and the potential for the large number of immunocompromised that we needed, Lisa mentioned that this patient population is quite large in the health system, in cancer and outside cancer. We came up with this criteria to identify who would likely benefit the most. And you can see here all the indication, and this is the first step. So we identify a patient population based on disease or treatment, acute leukemia, chronic leukemia, transplant, and others. But then we do a test to make sure or to determine if this patient responded or did not respond to vaccine. And based on that, we make the decision who would likely benefit from this dose. Next slide, please. So our current recommendation today, vaccination should be first with a completion of the primary series or a booster dose. 2 weeks after the vaccine, we're gonna measure response to that vaccine by a blood test, and the results of this test will guide whether Evashield can be beneficial or not. Patients who have low response to vaccination, as determined by this test, can receive the medication. We have the drug available in all our clinics and sites. So in terms of availability locally without having to travel to different locations, that is not an issue. Now, there are patients who are not eligible to receive the vaccine because of the treatment, like bone marrow transplantation, or we know based on a response to previous vaccine doses that have not responded, and those also can be eligible for Evashield now without the additional test. I just have one slide about treatment. We talked about vaccination, Evashield as another way to prevent COVID, but unfortunately, many of our patients and family and relatives do test positive. And want to share with you some information about the drugs that we have today to treat COVID on the ambulatory side. We also have different drugs in the hospital. There are 2 oral medication available today, Paxlovid and Molnupiravir, and there is 1 IV medication, Sotrovimab. All this medication are available today. Luckily, because of the number of infections are down in the state. You heard that earlier from Dr. Billingsley, and the number of hospitalized patients. So because of the numbers of infection is down and the supply are now been coming steady to the health system, we open our criteria where any of our patients, if they need any of this drugs, will be available to them. The choice of which drug, whether IV or PO, it depends on a lot of factors. Some of the oral medication have a lot of, actually both of them have side effects, one more than other, without going into a lot of details. So the right drug will depend for the most part on medication history, side effect profile, and what we think will work. We are updating our guidelines as we speak, and the newest version will guide clinician to the best option, again, for every patient. But drug-drug interaction is one factor, but there are others. I think this is my last slide. Thank you so much, and happy to answer any questions.
Scott, are you speaking as well, or are you here for questions primarily?
I'm here for questions.
Great. So if I can make 2 quick comments. One, although we don't know, many of us are very hopeful that we're really reaching the point where COVID is going to be endemic, not pandemic, and that life will very slowly become a little bit more normal, maybe with some peaks and valleys of having to step up our precautions. The one other thing I want to say, which is for the 3.8 million breast cancer survivors, is that, and I'm not contradicting Lisa, because I don't think that Lisa actually wrote some of all of those guidelines herself, but I know of no evidence that a woman who's had breast cancer and is on hormonal therapy with tamoxifen or an aromatase inhibitor is immunocompromised. So I have no doubt that in this audience, there are at least some number of women with breast cancer who are taking tamoxifen or an aromatase inhibitor. And I'm talking about women with early stage breast cancer. And I don't think you have to panic that you have to suddenly do something different in terms of your vaccination, because I don't think that you should be vaccinated and you should be boosted. But you don't have to worry excessively that you're immunocompromised. Of course, many, many of our other patients do need to worry about that. Lisa, are you okay with that comment?
Yes, I think early in the pandemic, when we were formulating the 3rd dose recommendations, the thought was to err on the side of being cautious and liberal, and that may be worth revisiting.
Yeah. But I just don't want everyone to worry too much about that. So our last speaker, and I think that the last 2 presentations have been pretty dense, and I think that this presentation may be a little bit less dense and a nice break before we get to the questions. So Dana Brewer is the Creative Expression Coordinator in Smilow, as part of the Integrative Medicine program. And she is going to speak to us about creative expression and integrative medicine. Dana, thanks so much. And of course, let me just say that our Integrative Medicine program is a very important part of what we do, something that many patients look to for help getting through their whole experience. And Dana is going to touch on this.
All right, thank you. Going to try to share a screen. Okay, so I'm Dana Brewer. I've been in the integrative medicine field for 20 years at Yale New Haven Hospital. I developed and coordinated the creative expression program within Smilow, so I've been doing that for the last 11 years. Integrative medicine offers care for the mind, the body, and the spirit. The goal of our program is to empower our patients with knowledge and support needed. We help improve and maintain quality of life through treatment and beyond. We offer additional avenues for wellness that we can help reduce some of the side effects of treatment. This is a sample of our virtual calendar for both patients and caregivers, because we recognize that being a caregiver is equally as important for these services. Tai Chi, Qigong. We also have pre-pregnant, you can watch them at your time. We offer outpatient massage and Reiki for people that don't know exactly what we do with integrative medicine. We have inpatient visits as well as at Smilow Cancer Hospital in New Haven. You can schedule by calling our department directly. You can get more information from us. If you're inpatient, you could request a visit as an inpatient through your care team. You could also schedule clinical consultations with Dr. Gary Soffer that can provide guidance on nutritional interventions and mind-body modalities. And all of this information is on the calendar and can be found at the Yale Cancer Center and Smilow Cancer Hospital at YNHH webpage under Integrative Medicine. And if you're on our email list, we send this out weekly to you, so you'll know what's happening. But today I get to also share one of our ongoing latest projects, and it's called the Origami Crane Project. The story of Sadako and 1,000 paper cranes inspired Jean Parkin to begin creating origami cranes with our Fairfield Woods Middle School students, their families, friends, and fellow teachers. Some of these beautiful cranes are hanging in the Healing Garden vestibule and became the start of this project. Since December, over 260 participants have created 1,651 origami cranes. That number continues to grow as we keep adding to the display. It was really important during this challenging time. It became a tangible symbol of peace, hope, love, and healing. And it provided connection for patients and our staff as well. The cranes that have been coming in are made from origami paper, wrapping paper, magazine, and book pages. And as more cranes arrived, I sort them by color, thread them, and I put them into the installation. The second part happened organically, and we titled it Woven Together. I had left one personal message of encouragement and placed extra strips of paper alongside the nest that was on display with the cranes. I left a single marker and, of course, hand sanitizer, but no directions. And then the magic started to happen, as usually does with these collaborative projects. And a dialogue ensued with messages for encouragement, gratitude, healing, and personal wishes from and for our Smilow community. Our youngest patients that visited the Healing Garden left messages, and I was there to witness one day, one of them writing, and he wrote, "Be brave," and he wrote, "I love you," and weaved them into the nest display. I want to thank everyone for supporting creative expression in our collaborative projects within the hospital, because I believe they're so important. And I invite you to visit our Yale Cancer Center Integrative page for more information on our services and how to, and if you choose to, and I hope you do, participate by emailing me your messages, which will be added to our nest. The messages eventually, with time and volume, becoming the nest itself. So that'll be the second part of the project. And you can also contribute to this project by still creating origami cranes. I'd like to share a quick 50-second video that popped up as a memory on my phone, and it will give you a glimpse into this installation. I want to thank you to everyone that participated thus far and those that are intending to do so, and all of our guest artists, past and present, that have made our collaborative project so successful. We'll be sharing more about this project and others on our social media platform.
Anna, thanks very much. There is actually a very lovely children's book about a young girl who lived through Hiroshima and who made cranes, origami cranes.
That was actually the catalyst for this project.
Awesome.
Yeah.
I used to love to read it to my kids. So it was really great. Before we get to some of the questions that relate to vaccination, I just wanted to ask you to give us a sense of what percentage of the patients in Smilow use the integrative medicine services, and how we might encourage more of that.
I think that with our virtual platform, we were able to reach many more patients and their family members. Currently, we see inpatients. We have people that are actively going upstairs. And I know with the Creative Expression program, our numbers have been really high because it's been very easy to participate virtually.
And, I think it's a good lesson that we've learned from COVID and from in terms of how we practice medicine and how we care for people during COVID. And there are some lessons that we're going to want to take into life post-pandemic. All right, I'm going to move on, and there were a number of questions that were submitted, and I'm going to turn to our panelists for these. So here's the first of them. I'm being monitored for CLL. My counts are slowly going up. I received a full dose of the Moderna vaccine as a booster a few weeks, and by booster, this would presumably be the third of this person's doses, a few weeks before the guidelines were published recommending a half dose. Should I now receive a fourth dose, or what we would now call the booster for this patient? I'm not going to call on people. I'm going to just let you chime in.
I can answer that.
You want to take it?
Yeah, so I specialize in CLL, and this is a common question that I address daily with patients. And so, patients with CLL, even without treatment, may not respond to the antibodies or not respond to the vaccines. And so, when we only had 2 vaccines, we told patients to take good precautions, to call us immediately if they had illness, so they could be treated with antibody therapy. And then a booster came, and we were really excited about it and thinking that those patients that didn't respond could respond. Many of those patients still don't respond. And so now we actually have other things like a fourth dose or a primary series in your booster, or Evashield. And so I think what we've developed here is, if you've tolerated your 3 series well without side effects, get a fourth dose, and that would be your first booster now with the revised CDC guidance. And 2 weeks after, 3 weeks after, have an antibody test. And if it's undetectable or less than 200, which is based off of CDC guidance, Evashield would likely be what we'd be recommending. And I think that is a general approach. And whether you had the booster Moderna or full dose Moderna, that is still being considered of how we would kind of address that. But in general, if we're using antibody levels now to kind of identify who might benefit the most from Evashield, I find that a more kind of rational thinking about how to identify those that are in greatest need for antibody prophylaxis with Evashield.
Thanks, Scott. The next question also or touches on antibody tests and is a fairly straightforward question. What does the antibody test mean in a 63-year-old who is immunocompromised?
So a level of 63. So I think the levels that we do obtain is semi-quantitative. We don't exactly know what the level means in terms of a reduction to the next variant or current circulating variants, but it tells us the antibody response, how robust antibody production was after the vaccination. And so based off of CDC guidance of using convalescent plasma, which used about 210 cutoff, that is currently what we're thinking are those folks that are most in need or most likely to benefit from Evashield. These numbers can change, but that is generally what we're aiming for after a full series 3 and a booster. If your level's over 210, generally we'd be talking about delaying Evashield or additional strategies in the future.
Can I just add one quick caveat to that?
Yep.
So the 210 applies to the Roche platform, which is what we use at YNHH. However, Quest, Greenwich, and LabCorp use different platforms, and so that number cutoff may vary depending on where people get the lab. But Scott's correct, for the Roche, it's 210. So the answer depends on where the lab was obtained.
Okay, next. I'm eligible for my 4th shot this month, but it hasn't been a year yet since I stopped Rituxan. There's a theme here in terms of treatment. My understanding is that it can take a year for my B cells to come back. Would it be better for people like me to wait for my 4th shot until I'm a year off Rituxan?
I could take that. I mean, this is a good question. And the answer is we don't know. There's a lot of uncertainty here. I think by adding this test-based strategy, the antibody-based strategy, we at least have some understanding about how robust the immune response is in terms of the antibody production. So I think following what we're recommending and having a booster, a 4th dose in this situation, and checking a level is informative, and things could change. We may recommend additional levels in the fall, but at least right now, this is I think a good approach to trying to understand timing away from rituximab and the antibody production after vaccine.
All right, so Sam, I'm going to give you this one. It's I think also pretty straightforward. The question is, can I go to the local pharmacy that gives COVID vaccine for the 4th vaccine?
Yes, but they follow the CDC guideline closely. So right now it says 5 months after your primary series, and until that change, any other duration you would be blocked. So they are consistent with our recommendation today. CVS has exactly the same.
All right. I had Pfizer, the first Pfizer dose in January of 2021, the second Pfizer dose in February 21, then a Pfizer booster September 30th. I'm 80 and in good health. When should I get a second booster? Lisa.
So if I understand what you said correctly, they got 3 Pfizer shots.
Correct.
And it's immunocompromised person asking the question.
Well, the person says that he or she is 80 and in good health.
Okay, so I'll answer it both ways. If they do not meet the criteria for being immunocompromised, then they had their primary series of 2 doses, and then they also completed their booster. So at this time, there's no additional action needed. If the person asking the question meets any of the criteria for immunocompromised and they completed 3 doses of Pfizer, then they completed their primary series for immunocompromised patients, and they would be eligible for their first booster 5 months after the first shot.
All right. So the next question is a little different, and certainly demonstrates that sometimes our patients try to take care of us. And the question is, when I come in for treatment, staff are very busy, many indicating that they're working double shifts. There are reports that doctors, nurses, and other clinical staff are working around the clock. Are staff getting the time to rest and reflect? Kevin.
Dr. Weiner, I think both Kim and I can speak to this. And I so appreciate the thoughtfulness of this question, because our teams have been working very hard. And we have been challenged over the past 6 weeks by both staff illness as well as some of the staffing challenges that healthcare organizations across the country have been facing. That being said, our frontline nurses in particular have worked heroically. We have been able to retain many of our nursing staff members, and I'm pleased to say that the rates of staff illness have dropped precipitously, and we're back on a very stable footing in terms of our staffing, both for frontline clinicians, physicians, APPs, and nurses. And Kim or Lisa, you probably have additional to add to that.
Thanks, Kevin. I think the only thing I would add is we wish that our staff and our providers had more time. We are trying to provide them lots of resources and avenues to provide, to give themselves self-care and take that time. But we have been leaning on every single team member. And there are times where they are working extra shifts. And our teams across all of Smilow have been helping each other out across sites and across inpatient and outpatient settings to make sure that we're taking care of our patients. And so, again, I can't extend my gratitude enough to the teams. And again, I want to say exactly what Kevin said. It's very thoughtful and caring that you care about us as much as we care about you. But this is a very disruptive time across the country, in particular with nurse staffing. And we are really doing everything we can across the health system to be innovative and stabilizing our workforce. But it has been a difficult 2.5 years for healthcare providers.
If I can just add a comment. We're really dealing with two separate issues. One is that for a number of years, there has been concern about physician burnout and, for that matter, nurse burnout. And, this has been a commonly discussed problem. And then we're also dealing with the so-called Great Resignation that has occurred associated with the pandemic. I think that what we try very hard to do is to support all of the staff, the doctors, the nurses, the pharmacists, the social workers, everyone who is there. And I don't think that we can overstate the importance of doing that, because the truth is, and this is, I think, what is partially implied by the question, is that when people are not feeling up to themselves and when they're not functioning at 100%, it's hard for us to do our jobs. So as a group of leaders, we are trying incredibly hard to make sure that during all of this, that we're taking care of the people who work at Smilow, and that we're setting them up for success in patient care encounters, because that's what we need to do for all of you. I think we probably have time for one last question. And I'll pick the last question that was submitted on my sheet. If one continues with no immunity, what is the recommendation for a second booster for spouses or other family members living with the patient? Is there something unique or special that should be done for those family members to give them extra protection? Scott, do you want to take this?
Yeah, at this point, the general consensus is if you are not immunosuppressed and you have a primary series of 2 vaccines and a third shot for booster, you are fairly well protected at severe illness. As a virus that will become endemic, it will occasionally circulate, and many or most of us will be exposed. And I do worry about our patients long-term, that those that are on immunosuppressive agents may not have a response. And so Our vaccination policies are important. Precautions when the pandemic or endemic is raging is important, but also having treatments are incredibly important. So Sam had a nice slide at the last, basically showing the treatment options. And for our patients, that will be very important going in the future. Whether you've had vaccinations and then are treated with rituximab or other important therapies, you may lose the response, and having a backup, having treatments is really critical. And knowing that the current variant is sensitive to the current treatments is also very, very important. So the Omicron pandemic was quite difficult for us because we lost some important therapies early with Omicron. We now have new therapies that are effective. And so having, your oncologist on speed dial, and if you have concerns about COVID, calling and asking about are there treatments if you are exposed, that is a really critical, importantly thing to know going forward, because this is something that we'll be dealing with really for the months and years to come.
And Sam is the one person who hasn't made a comment in this question and answer period. I'm going to give him a chance to make a comment, but first let me just say that in my mind, the hidden heroes from patients are the pharmacists, the radiologists, and the pathologists. You don't necessarily always see the pharmacists who are back mixing chemotherapy, checking to make sure that our patients get exactly the right drug dose, making sure that there isn't anything that needs one more check, one more question. So Sam, any final comments?
Thank you, Dr. Moiner. Nothing really other than I'm glad to be here, happy to do whatever we can to help our patients. I think this is a great team, and we approach everything as a team. Don't always wear my pharmacist hat. We're all just one team and do whatever is needed.
So I want to thank all of our speakers and panelists. I want to thank Renee Gaudet, who is really the hidden person here, who has put all of this together and organized us all and does this so seamlessly time after time. And I want to thank all of you who attended. It was really great having you. I hope this was helpful to you. And if you have suggestions for topics that you want us to cover in future sessions, please reach out and let us know. And with that, good night. Have a good upcoming weekend. Bye-bye.
Right.